deciduous dentition. Then you also have the permanent dentition. So in deciduous dentition, there's indirect pulp capping, there's direct pulp capping. Today we are going to focus on pulpotomy and pulpectomy, and I will explain why as we go along. Again, the scope of the topic, when you're looking at permanent dentition, is primarily in immature teeth, and that's where apexogenesis and apexification come in. So this is just the scope of the topic if you're looking at endodontics in pediatric dentistry. However, we'll be talking about pulpotomy and pulpectomies today. So, I'm very glad to be speaking with all of you. Just a second. There we go. So a brief introduction. Pulp therapy, as we all know, the purpose of pulp therapy is to maintain integrity and health of the teeth and the supporting tissues. The objective is typically to maintain vitality of a tooth affected by caries, trauma, or any other causes. And this can be achieved by two methods in deciduous teeth, either by pulpotomy or by pulpectomy. And the aim is really to save the tooth so that it will maintain the integrity and function of the dental arch. We all know the functions of our milk teeth, why they're important, and the idea is to maintain them for as long as possible until they're able to exfoliate naturally. So, however, there are instances where you may not be able to save a tooth. So when do we extract deciduous tooth? In cases where the infectious process cannot be arrested by your therapy, bony support cannot be regained, a tooth that is not restorable, and where there is excessive pathologic root resorption. So it's about decisions. And of course, as again, all pulp therapy, it's recommended that it's performed with rubber dam or other equally effective isolation, but really it's rubber dam because we want to minimize bacterial contamination of the treatment site. So let's first look at some of the differences between primary and permanent teeth. I have found that in, of course, undergraduate training, even postgraduate training, the focus is always so much on pulp therapy in permanent teeth. So let me take us back a bit so that we can look at the differences between the primary and the permanent teeth and the significance when we are looking at endodontics. So when we look at the anatomic features, the overall size, of course, primary teeth are smaller, and yet the pulp chambers are larger as compared to the crown. And this gives you such an ease of access opening, which you may not typically find in permanent teeth. There is marked cervical constriction. And the significance here is that there's a higher likelihood of perforation, so you have to be careful. The root trunk is short with a thin floor of the pulp chamber. So there's also easy phaco involvement. Then when we look at the root anatomy, the roots in primary teeth are thin, they are ribbon shaped and they are flared. So there's limitation in canal enlargement. There's only about size that you can go when you're instrumenting. Typically up to a size probably 25 on a distal canal, but that is, you know, there's a limitation. There's a high risk of instrument breakage and also a high risk of perforation when you're dealing with the primary teeth. Accessory canals are quite a number, and they are frequently present in the furcation area and the roots. We'll see more about that. So a lot of the time you may not be able to completely extirpate all the pulp that you'd like to extirpate. But one of the good things that primary teeth are really kind to our techniques. So what are the histological differences? Here we're looking at the macro. Histologically, the apical foramen in children in primary teeth is enlarged. And this means that there's an abundant pulp supply and also an exaggerated inflammatory response. Then the pulp function in children in primary teeth, there's formative, nerve supply, resorptive as well, so that degeneration of these neural elements are less sensitive to operative procedures, which is why we can do a pulpotomy and the tooth will, survive until it is time for its exfoliation. The cellular response to injury is more extensive in primary teeth. So you have an incidence of reparative dentin formation is more. There's localization. When it comes to infection and inflammation, localization is poorer in primary teeth. So that's why in children you'll see more chances of cellulitis and abscess formation, which is a bit more rare in permanent. So there's less innervation. So I'd put this in quotes, that less sensitive to operative procedures. The sensitivity is quite the same, especially because of the abundant nerve supply. You'll always find that the inflammatory response is quite large. So I would say the sensitivity is not that less. The pulp nerve fibers end at the odontoblastic layer. And then when it comes to calcium hydroxide, which we shall discuss a bit more, in primary teeth, the response is quite severe. And there, we are going to look at how internal primary root resorption comes in. Okay, so what is a pulpotomy? There's, of course, definitions keep coming and going. And basically, the simplest is amputation of our coronally infected pulp tissue. And the objective here is to maintain vitality and then maintain the function of the radicular pulp. So I would go with the second definition more. What are the treatment objectives of a pulpotomy? Amputate our infected coronal pulp, neutralize any residual infectious process. So here we are going to look a lot at the medicaments that are used and which one is better than the other, and then preserve the vitality of our radicular pulp. So what are the indications? We have cariously exposed primary teeth when retention is more advantageous than extraction. And as I've said before, retention is really more advantageous than extraction. So the second indication is when inflammation is confined to the coronal portion of the pulp, and when caries removal results in pulp exposure. You're doing a class 2 and you see a pink spot. So in this case, you have a normal pulp or there's a reversible pulpitis after a traumatic pulp exposure. What are the contraindications? I think these are even more important to take note of than the indications, because a lot of the time we're looking at your pulpotomy or whether to do a pulpotomy or a pulpectomy, but typically these contraindications will help you to rule out, what you should not be getting into. So one, if you have a swelling, a fistula, you have any sort of suppuration, pus formation, a non-restorable tooth crown. We talk a lot about Endodontics. Yes, a non-restorable tooth crown, you are really wasting your time and the child's time by trying to do a pulpotomy, because the tooth will fracture and then you end up having to extract roots. Absent or profuse hemorrhage. Of course, absent just means pulponecrosis has taken place. And then if you open up, you're in the coronal pulp and you have amputated it with your slow speed knives and you're irrigating, but there's still more and more bleeding happening, uncontrollable bleeding that is now irreversible pulpitis. So there you have to go in and do a pulpectomy, not stop at a pulpotomy. If there's marked tenderness to percussion, although we know that with children, when you're detecting tenderness to percussion, you may not really get a true positive. When there's mobility of the tooth, radiolucency in your furcation or periradicular area, radiographs, very, very important aid to your diagnosis and to guide whether or not you are going to, the decision tree really. Radiographs are very important. If you have a necrotic pulp, dystrophic calcification, and of course there's pathologic resorption. Again, let's revise the objectives in pulpotomy. The objectives are that your radicular pulp should remain asymptomatic. without any adverse clinical signs or symptoms. And these symptoms usually are sensitivity, pain, or swelling. There should be no postoperative radiographic evidence of any external root resorption, which is pathologic. Of course, you'll see your D's and E's depending on the age of the child that this is not physiologic resorption. Now, internal resorption, a lot of the time is actually expected depending on the material, depending on the medicament you've used, but it's typically self-limiting and stable. So it is important to keep monitoring this internal resorption. And if perforation is causing loss of supportive bone and there are signs of infection, then the tooth is extracted. And then very importantly, there should be no harm to the succedaneous tooth. So there are 3 treatment approaches for pulpotomy. There's an author, she's a professor, Anna B. Fuchs. Her reference, you'll see it at the end. She's done a lot of work, a professor in Israel, done a lot of work from, I think, the mid-90s regarding pulpotomies, pulpectomies. So there's a paper that she authored with another professor talking about the approaches when you're doing a pulpotomy. You're trying to devitalize a tooth, preserve, or regeneration. So these are the 3 treatment approaches when we are looking at pulpotomies. So devitalization, what medicaments do we use? What techniques, what equipment do we use? So there are 3. 1 to 5 diluted formocresol, that is Barclay's technique. This in undergrad, it was a mainstay. We talk about it a lot. We are going to compare, look at some of the studies that compare, and also talk about formocresol, because formocresol in the recent years has been getting a really bad rap over its mutagenic properties. We'll talk about that a bit later. So when we're doing devitalization, a second technique is to use electrosurgery, and then the third is to use laser. Now, preservation, here you can use ferric sulfate, glutaraldehyde, or MTA, mineral trioxide aggregate. Then the third is regeneration, bone morphogenic protein. There are studies that have shown that they actually bring about regeneration, freeze-dried bone, and then MTA again. As you can see, as you go towards regeneration, there are less and less studies that are talking about it. Most of them talk about 1 and 2. So technique, we've spoken about isolation. Have your rubber dam clamp your tooth as best as you can, because it's very important. Again, we all know the advantages of having a rubber dam isolation. I will not really go into that, but just emphasize that we are trying to limit contamination, because again, your job is to, you're trying to make sure that your pulp, you're trying to maintain vitality of your tooth. So you need to anesthetize the tooth and the tissues. Although laser, tries to say that there's pain reduction, so not so much, but ideally anesthetize, isolate, create your access, excavate or carious dentine. Once you remove the dentine roof of the coronal pulp chamber with your high-speed around bar, a fissure bar, but mostly around bar, you start to remove your coronal pulp tissue with a slow speed. Again, the flow, when I've already shown you the slide about the anatomy and how the flow of deciduous molars, deciduous teeth are already perforated. So it's very easy for you, if you're going with a high speed, to just, perforate, and you cannot continue with your pulpotomy. So switch to a slow speed and then remove your coronal pulp tissue. Thereafter, start to achieve hemostasis with dry cotton pellets under pressure. And then, dry cotton, some sources will say use wet cotton pellets that you have soaked in normal saline or irrigate with normal saline and then apply pressure with a cotton pellet. And at that point, you should have a nice clean floor. You can see a nice clean floor and just your orifices of the canals that you expect to see in either your DOE or even your anteriors. Thereafter, depending on whether you're doing devitalization, you're doing preservation, apply ferric sulfate solution. So ferric sulfate solution, we are going to talk about the different medicaments a bit later. Typically use 15.5%. When you're using ferric sulfate, it's just 15 seconds. If you're using formocresol, there's 3 to 5 minutes. And then the pulp stamps, you should be able to see the pulp stamps and they'll appear dry. Thereafter, you place your GI, your zinc oxide eugenol in contact with the pulp stamps. Although typically put your zinc oxide eugenol or your MTA before placing your GI. And then very importantly, place a stainless steel crown or bonded composite. So this image just really shows, it's a infographic of what I've just been talking about. So after the coronal pulp chamber is filled with, is this me who has written on this? If after it has been filled with a suitable base, you should restore and seal the tooth from micro leakage. And again, the most long-term effective restoration is a stainless steel crown. Endodontics in adults, when you are doing root canal therapy, we always tell the patient, ideally you should crown your tooth thereafter. Same thing with deciduous teeth. It's very important that after you've done you've sealed your tooth to prevent micro leakage with either Zoe, with GIC, place a stainless steel crown. With pulpotomy, immediate placement is recommended. And of course, depending on the behavior of the child that you're seeing, the time your appointment is, sometimes you may not be able to do it all in that one visit, but plan. Please plan for placement of a stainless steel crown after you have done a pulpotomy, because you want your tooth to last the duration that it is supposed to. So in cases where there's sufficient supporting enamel, you can place an amalgam or a composite resin, and this will provide a functional alternative. But this is when the primary tooth has a lifespan of 2 years or less. If you have a 4-year-old, a D and E, place a stainless steel crown. So let's talk about the different medicaments that are used for pulpotomy. So some of the properties of formocresol, it's fixative, it induces that chronic inflammation, but the disadvantage, and research studies have shown that it is possibly mutagenic, carcinogenic. As with, the way the controversy with amalgam is, there'll always be groups of people that are saying, you can't use it anymore, it has these properties, and then there are others who are saying, it's just possibly mutagenic. However, it has an 88% success rate. And then those are the components that you see in it, and it's used for 5 minutes to achieve hemostasis. So what it does is that, as I said, it's fixative, it prevents tissue autolysis by binding to protein. Formocresol, the thing is, when you look at some of the papers that compare formocresol and, let's say, ferric sulfate, which we are going to talk about, I guess at the end of the day, if there's a better alternative, if there is a product or a material that is offering better advantages, it's always better to go with that one. Something's happening. Okay. So this is just what I've been saying. Although it's purported to be a gold standard for pulpotomy in primary teeth, I know most of us will be like, what do you mean it's a gold standard? It actually is, according to the literature that is out there. Concerns have been reported regarding its safety. So better alternatives are being developed. And these are some of the alternatives. We have ferric sulfate and then MTA. I mentioned glutaraldehyde for preservative, laser. Let's look at all those one by one. So what is ferric sulfate? It's an astringent, hemostat. A lot of us use it in achieving hemostasis when maybe a crown prep, achieving hemostasis around the margin lines. So it forms a complex as well that mechanically occludes a capillary. In pulpotomies, 15.5% ferric sulfate solution is used for 15 seconds to achieve hemostasis. And this is solution, not the gel. And the gel is much more easily available. But here it is recommended to use a solution. It has less inflammation than Formocresol. 92.7 success rate. This is more radiographic, 100% clinical success rates with ferric sulfate. So the thing is that, ferric sulfate is showing up as a more superior. It has less safety concerns as a medicament for pulpotomies. The other thing is that root resorption is not accelerated, no systemic or local side effects. Internal root resorption is similar to that in Formocresol. So glutaraldehyde in preservative, if your objective is to preserve, it is superior, non-reversible fixation by X-linkage. The diffusibility is limited, so you'll just have a few millimeters of your radicular pulp fixed. It's an excellent antimicrobial agent. It causes less necrosis of pulp tissue, less significant immune response, minimal systemic distribution, and 98 to 100% clinical success. However, I have not come across a formulation of glutaraldehyde used for pulpotomy. What I've used in my experience and in training has been Formocresol and ferric sulfate. Third is electrosurgery and laser. This is a new evolvement in pediatric dentistry. Laser is really being pushed because the effects, the pain is reduced, and also there's no sound with the motorized handpieces. So, however, it is less successful than ferric sulfate or dilute Formocresol. So this offers a non-chemical devitalization. What it does, it carbonizes and heats, denatures the pulp, and then denatures any bacterial infection. So in the diode laser pulpotomy, those are the measurements that I use to achieve hemostasis of the remaining pulp. MTA has been a big deal for a few years now, but mostly for immature pulps, apexogenesis, apexification, but it's also very useful in pulpotomies. The paste is allowed to dry to cover the pulp stump. Instead of using Formocresol, you just place the paste there. That is the ratio you use when you're mixing. And then after that, place an intermediate filling. However, as we all know, the cost of MTA always, limits its clinical use. But trials are showing that it performs equal or better than Formocresol or ferric sulfate, and is going to be the preferred pulpotomy agent in the future. So these are some of the studies that compare different techniques used in pulpotomy. So this study done in 2014 by Damos, it was in vivo. It was designed to assess clinical and radiographic success rates of primary molars treated by pulpotomy using either a diode laser, sodium hypochlorite. Sodium hypochlorite is, I think here it was being used as a control or something like that, because in most texts, in most literature, sodium hypochlorite is not typically a medicament used in pulpotomies. However, the 2-year clinical success rates for primary molars treated by using diode laser, sodium hypochlorite, or no medication were actually 100%. After 2 years, the teeth were asymptomatic. There was no pain, no sensitivity, no signs of infection. Then the radiographic rates for diode, 9.9%. For hypochlorite were 100%. Again, I guess because one, hypochlorite is a hemostat, and also it has hemostatic properties and also antimicrobial. But with no medication at all, meaning after removing the coronal pulp, achieving hemostasis using pressure, maybe zinc oxide was placed directly on the pulps. That is no medication, but radiographically the success rates were 87.5%. However, when the pulpotomy was performed by less experienced residents, a reduced overall success rate was found when compared to those more experienced technicians. So it is a technique sensitive procedure. So when comparing diode laser, formocresol, and ferric sulfate, so the clinical success rates at 12 months were 97% for formocresol, 95 for ferric sulfate, and then diode laser, 100%, that's clinical. And then interestingly, the radiographic success is a bit the other way around. With formocresol, it's 87%, ferric sulfate is 79%, and then 75% with diode laser. So you see that formocresol, 95 and then 87, ferric sulfate 100 and then 79 when you do clinical against radiographic. But the difference in the results were not statistically significant. So in conclusion, diode laser really offers a high clinical success rate. However, not when you consider radiographic, it's not as high. And so it may not really replace traditional formocresol and ferric sulfate pulpotomies in primary molars. So longer term studies, these were for 48 months. Effects of ferric sulfate to that of full strength formocresol. There was 96.4% clinical success rates when using ferric sulfate, 97 in the formocresol groups. Whereas radiographic, 92 for ferric sulfate and 94% in formocresol. As you can see, there's really, formocresol is performing better in these studies, but as we said, there are safety concerns. And when it comes to radiographic success rate as a pulpotomy agent, ferric sulfate is also performing quite well. So because of its lower toxicity, it is fast becoming a replacement for formocresol in managing primary molar teeth. So how about using MTA or formocresol? So success rate of pulpotomy, 97% for MTA compared to 83% for formocresol. 8 teeth presented in internal resorption, but the process of resorption stopped and the pulp tissue was replaced by a radiopaque calcified tissue. As I'd mentioned earlier, there's almost always, because of the neural nature of the pulps of primary teeth, there's almost always an internal resorption that takes place, but it is self-limiting. So MTA shows a higher, although it's not statistically insignificant, long-term clinical and radiographic success than formocresol. So it can replace formocresol, and it doesn't induce undesirable responses. As mentioned earlier, that pulp capping is also part of endodontics, although we are talking more about pulpotomy and pulp capping. But in cases where, either you have exposed your pulp doing a routine restoration, indirect pulping has been shown to have higher success rates than pulpotomy in long-term studies. and it allows for a normal exfoliation time. So it is preferable to pulpotomy when the pulp is normal, diagnosis of reversible pulpitis, and when you don't remove carious dentine, all the deepest carious dentine, because you actually are trying to avoid pulp exposure. According to the American Association of Pediatric Dentists, we are all, the idea is to limit, we're not into expansion for prevention anymore. You can leave a bit of carious dentine to avoid pulp exposure, do an indirect pulp capping with a setting calcium hydroxide, and then restore the tooth. It will actually have higher success rates. Okay, so it indicates that there is no conclusive evidence that it is necessary to re-enter a tooth to remove residual caries. The school of thought previously was that you first place your, do your indirect pulp capping, and then place an intermediate, an intermediate restoration, then come back, because you expect to have a secondary dentine laid down, come back, remove everything, make sure that you scrape your dentine and it's hard and it's shiny, it's not soft anymore, and then you restore. But now there's no need to do that. So as long as the tooth remains sealed from bacterial contamination, the prognosis is good for the caries to arrest and for reparative dentine to form, protect the pulp. Okay, so that is it about pulpotomy. Let's talk about pulpectomy. This is definitely a non-vital technique. We are aware of pulpectomy in permanent teeth, involves actual removing of the roof, the contents of necrotic pulp from the chamber, and the root canals. So pulpectomy is a root canal procedure for pulp tissue for irreversibly infected or necrotic pulps due to caries or trauma. The canals are debrided, enlarged, disinfected, and then followed by filling the root canals with a resorbable cement. So here we're also going to talk a bit more about the different materials that we use to obturate teeth, primary teeth. So as you can see in the images, you have your orifices there, quite clear, and then the radiograph is showing the filled roots as well as the filled pulp chamber, and then crown. So what are the treatment objectives of a pulpectomy? You want to maintain the tooth free of infection. You want to mechanically cleanse and then obturate your root canals. You want to promote physiologic root resorption, and then also hold the space for the erupting permanent tooth, because we all know a tooth is the best space maintainer for in children. So what are the indications? Of course, a cooperative patient, even in pulpotomy, a cooperative patient is always best. But because here you'll take a bit longer, the technique is a bit more sensitive, a cooperative patient is imperative. Then teeth with poor change of vital pulp treatment. For example, you have, you're trying to do a pulpotomy. As I said, you open up, you're in the coronal pulp, you have amputated your coronal pulp and there is still excessive hemorrhage. You're unable to control it with a damp cotton pellet. That just means you have to go in and remove the radicular pulp as well. So the other indication is strategic importance of, you want to maintain that space because a tooth is still the best space maintainer. Other indications, pulp necrosis, you have an abscess, absence of severe root resorption, absence of surrounding bone loss, when you know you can restore your tooth, and then teeth which have no pulps with no fistula. Now, there are two schools of thought from what I have seen and read, especially I think in the AAPD versus, let's say, the British Paediatric Dentistry Association. When it comes to dental abscess, it appears as though if a child has a dental abscess, extract the tooth, even if it is restorable, but There are some schools of thought that, when an abscess is present, don't even attempt to do a pulpectomy, extract the tooth and place a space maintainer. Whereas according to the American Association of Pediatric Dentists, even if you have an abscess, you can still try and do your pulpectomy, as well as you should, and the tooth will survive. We are going to see success rates of pulpectomies. So this reminds me of, I think about quite a while ago, Dr. Ken Chapman was presenting on root canal for an abscessed tooth and why you should still try and do, to save the tooth. His argument was that, regardless of the fact that there's an abscess and maybe if the tooth is restorable and your radiograph is not showing excessive bone loss and all of that, try and save the tooth. And that's what I usually recommend to patients and to colleagues. You have an abscess in a 4-year-old on a D or an E, always try and do your pulpectomy. Try and save the tooth and give it a fighting chance. If it fails and the abscess is persistent, then you can extract, but at least you tried. And the thing is, you'll see that, based on different studies, the success rates of pulpectomies in cases when it's done, when the diagnosis is an abscess, are actually not that low. They are not that bad. So what are the contraindications for pulpectomy? Teeth with non-restorable crowns. Again, a lot of the time, if you can't restore your crown, you can't place a stainless steel crown, then there is no use doing the pulpectomy. When there is involvement of the radicular involvement is extending to the secondary tooth bud, when you have a lot of resorption of at least 1/3 of the root, there's a tract. When you have excessive internal resorption, excessive pulp flow opening into the bifurcation, if the patient has a systemic illness and any underlying. So those are some of the things. Again, radiographs, you'll need an OPG, you'll need some bite wings to be able to see all of these things. So what are the objectives? Following treatment, your radiograph process should resolve in 6 months, as evidenced by bone deposition in the pretreatment radiolucent areas. And then the clinical signs and symptoms should resolve within a few weeks. So that is the objective. There should be radiographic evidence of a successful filling with no gross extension or underfilling. Then the treatment should permit resorption of the primary root tooth, and the filling material should permit normal eruption of the succedaneous tooth. So that's why we do not use gutta percha when obturating deciduous teeth. Of course, there should be no pathologic root resorption or apical radiolucency. So the technique is to medicate of course, there's also, when you look at some of the guidelines by AAPD, again, medicating on antibiotic use. As long as there are no systemic manifestations, the child has no fever, it's preferable that you do the procedure. You don't have to medicate. But then if you have an abscess, a non-draining alveolar abscess at that, medicate. Here they talk about penicillin, but we know that in Africa, we do our combination of penicillin together with metronidazole, and it really works well. Enter your pulp chamber, extirpate and irrigate. File short of your radiographic apex and instrument only to the point of resistance. And then how do you remove your organic debris? By irrigation. Irrigate periodically with hypochlorite, dilute hypochlorite, and normal saline. Here it is 1%. So it is important that you also use your sodium hypochlorite because you're trying to disinfect as you go along. If you're doing a pulpectomy and you only use saline, yes, you'll be able to, mechanically disengage any of your debris and wash it out, but use your hypochlorite as well so that you can disinfect your canals. And this is why it's also important, of course, again, to have a cooperative patient and to make sure that you're isolated so that there's no injury from your hypochlorite. Chlorhexidine is also recommended as an irrigant, so it is also an option. After you have irrigated, you remove your debris, you dry with paper points. Then to obturate your canals, there are several materials that are recommended, and they ought to be resorbable. So you have non-reinforced zinc oxide eugenol, iodoform paste, that is KRI, a combination of iodoform and calcium hydroxide, Vitapex, we've come across this, and Endoflax. I've not seen Endoflax, but it's also used to obturate canals. Thereafter, after you've obturated, you pack the mixture. If you've seen Vitapex, they are pastes. So if you're mixing your zinc oxide eugenol, mix it as a paste, not as a stiff mix, and introduce it into your canals. There are different materials, different equipment that you can use. You can use your finger spreader, introduce your material into the canals. Some of these combinations, Vitapex, they come with a very nice long tip that will reach to your stop, and you introduce it. There's also rotary means of introducing all these obturants into your canals. After you have obturated, you pack with a stiff mix of zinc oxide eugenol, and then you fill either with reinforced Zoe, GI, and then definitely place a stainless steel crown. Some of the time, depending on how, let's say, you have your assessment of your tooth, if it is, you're concerned about the radiolucency, before you place your stainless steel crown, you may give it some time, a month, 2 months, to see whether or not your post-treatment radiograph, there's improvement in the radiolucency before you place your stainless steel crown. But it is recommended that you place your stainless steel crown. So what are the ideal requirements for materials used to obturate deciduous teeth? They should resorb at a similar rate. They should be harmless to the periapical tissues and the permanent tooth germ, have a stable disinfecting power, easily placed in a root canal and then removed, should adhere or be non-soluble in water, radiopaque, and should not discolor the tooth. So let's talk about the iodoform paste, KRI. It contains parachlorophenol, camphor, and menthol. It's highly resorbable. Advantage, it's bactericidal, promotes healthy tissue growth at the apex, and its success rate is 84% versus 65% with Zoe. So this one comes quite highly recommended. This is just a pictograph to show the process that you take when you are doing your pulpectomy. So this is a study that was done comparing Zoe and KRI. And as I said before, the success rate with KRI is 84%, while 65% for zinc oxide eugenol. And actually, overfilling with Zoe led to a failure. You should not overfill. That's why you stop before the radiographic apex of the tooth. So the results support the clinical efficacy of root filling with KRI paste as a treatment option for non-vital primary molars. So the success rate of pulpectomy, it's not high, but it is high. Although periodic checkup is necessary to monitor success and to intercept any failure-associated problems. Of course, as failure-associated problems will be things like your abscess is persistent, again, they're symptomatic, it's painful, tender to percussion, mobility is getting worse. So the tooth should remain asymptomatic, it should resorb normally, and should not interfere with the eruption of the permanent successor. So if there is any evidence of pathosis, extract and plan space maintenance. So pulp therapy requires periodic clinical and radiographic assessment of the tooth and supportive structure. Again, this is because you are keeping in mind that you have a succedaneous tooth waiting to come out there, so you want to protect it. So clinical assessment should be performed every 6 months, and it should be part of the patient's periodic comprehensive oral exam. So patients who have had an acute dental infection, they may require more clinical reevaluation. A radiograph of the primary tooth pulpectomy should be obtained immediately following the procedure to document the quality of the fill and to help determine the tooth's prognosis. It's also, of course, a baseline, a reference point for your future films. Then radiographic evaluation of pulpotomies should occur at least annually because the success rate of pulpotomies diminishes over time. So bite-ring radiographs ought to be under the patient's periodic examination, and typically they'll display your interradicular area because that's what you want to see. If this is not possible, a periapical image is indicated. So when it comes to what are some of the factors associated with failures in primary teeth? Most failures will occur within the first 3 months. So if you survive the first 3 months in a 4-year-old, you're really glad, you know that, and you've crowned your tooth, you know that this tooth will last its lifetime, and at 10, 11, it will exfoliate naturally. So teeth with carious lesions at the start of treatment presented more failures than those with a history of restorations or trauma. Of course, carious lesions, you have bacteria in there, so the likelihood of it failing is higher. Then once the tooth is restored, your endodontically treated tooth is restored with composite, the chances of survival are higher than ones filled with GIC. Although this is also disputable because depending on the GIC that you use, and if you crown, whether or not you crown your tooth. Pulpectomy is performed in 1 or 2 or more sessions, resulted in more failures. And I think this is also something that is coming up in endodontics in permanent teeth. Ideally, you should be able to perform your pulpectomy in 1 visit and close up. Again, this reduces the exposure, the risk of contamination over multiple visits. Patients who had gingivitis, this is poor oral hygiene. Of course, they had more failures in the endodontic treatment. The failure of root canal treatment in primary teeth was more prone to occur in a short time when the treatment was performed in teeth presenting with carious lesions. This has already been mentioned. And again, using composite instead of GIC increases the survival of pulpectomies. So initially, when we are looking at things like apexification, reimplantation of avulsions, we all know they are not indicated for primary teeth when we are talking about endodontics. So these are some of the texts that I used to develop this presentation. These are some case studies. This patient, this is WMM, 6 years old. She came complaining of pain on that 7-5. You can see 7-4, 8-4 have those class 2 lesions. These were just dentine caries restored with GIC. However, the 7-5 was non-vital, and the radiograph, you can see it, where is this? On the right here. And this is the post-op treatment. This really shows the ribbon nature and the slender nature of the roots of deciduous teeth. And then you can compare the interradicular radiolucency in the post-op radiograph and then the after obturating the teeth. There's actually resolution in the infection. So this patient did not have post-op. She was a referral. She did not have post-operative photos, but I first saw her when she was 3.5 years. Then she went somewhere. Compliance was quite poor. She went somewhere else, had the tooth extracted. Interestingly, what looks like a really large cavity on this tooth had been restored with GIC, the 8-5, as you can see here. So I was able to do a pulpotomy on it, do pulpectomies on the 7-4. She got the H4 extracted somewhere else. So after restoring, putting stainless steel crown, we're able to put a space maintainer. This was when she was about 5 years old. So that is it for my presentation. I thought I'd take less than an hour, but it has taken much, much more. So Denik or Dr. Matovu, I am open to questions.
All right. Thank you very much, Dr. Samantha, for the wonderful presentation. We have a couple of questions. Are you ready?
Yes, please.
Okay. The first question is coming from Dr. Maria Goroti Nakioni. She thanks for the presentation. And the question goes, I need more insight on regenerative endodontics in early permanent dentition, success rates, indication, and contraindications.
Okay. So that is actually another whole presentation. So today I was talking more about pulpotomies and pulpectomies in deciduous teeth, but yes, endodontics in pediatric dentistry include apexogenesis, apexification. I cannot go into all of that now because it is really wide, and as Dr. Natoni has said, there is a lot of literature on it, on the success rates. That is another topic for another day. I did not include it in this one because I did not have case studies, personal case studies that I could include in the presentation. So it would be a really purely academic presentation. And I don't have, like, let's say, you know, when you have a record of photos over time or follow up. So that one is for another time.
Okay. There's another question from Dr. Kayawula Emmanuel.
Yes.
He says, there are some colleagues who mix sodium hypochlorite solution with normal saline as an irrigant. What's your say on this?
Okay, according to the literature, you ought to use both when you're irrigating. But the normal saline is, I mean, the hypo is diluted to 1%. So you're irrigating, you're using that for its antimicrobial effects, and then you dilute, you irrigate further with normal saline. So mixing the two is not really necessary, but use your hypo 1%, irrigate, and then also irrigate with normal saline, like wash and rinse kind of thing.
Okay. Yes, there's another question still from Dr. Maria. Are there any studies concerning iodine as an irrigant in pulpotomy?
No, there's no literature actually that talks about iodine as an irrigant in pulpotomy. In pulpotomy, in pulpectomy, because I've heard about that, but I've not come across it in, at least in mainstream literature and in as I was preparing this presentation. So in as much as in pulpectomy, KRI has iodoform, but iodine as a no.
Okay. All right. There's another question still from Dr. Kayawula. It says, in case a pulpectomy fails before tooth exfoliation time, would you redo it?
Depending on the age of the patient, and also considering what you see on your radiograph. What are the radiographic symptoms? The radiographic, you know, if the information you're getting, if you see that your periradicular radiolucence is extending to the succedaneous tooth, yes, I would extract it. But if it is not, this child is 4 years old, this is an E, and I don't want to lose my E before time, I would redo it. If it is a referral, I've also redone them. And the thing is that if it is obturated with zinc oxide eugenol, it comes out quite easily with a bit of instrumentation and copious irrigation. I would redo it.
Okay. There is another question from Dr. Mariam Shahid. Says, great presentation, doctor. Thank you very much. Doctor, can we use Vitopex or Viapex for pulpotomies also as a base medicine?
As a base medicine, one of the, no, I would not recommend it as a base medicine, because one of the things about the properties of Vitapex and what's it called? You've mentioned Viropex, iodoform, is that there's that resorption component that they have. So if you place it on vital, see your radicular pulp, especially if you've just used, let's say, you've just devitalized. If you use KRI, any of those iodoform pastes, you're going to promote more internal resorption that you don't want yet in a pulpotomy. You don't want that in a pulpotomy. So no. I've also not come across any text that say that you can use it as a base. But also it's consistency, it's a paste. You want your base to be firm so that you can put your restoration on top, your GI or whatever you're using to restore.
Okay. There is another question from Dr. Paulo Msherure. Yes. Great presentation, doctor. As you mentioned, we have moved from dilute FC here in the US due to the mutagenicity. Studies have shown systemic presence of formaldehyde from pulpotomies. I think is clarifying. I personally use ferric sulfate for my pulpotomies, always restoring with stainless steel crowns. There's also another question from Dr. Kathe Mwesigwa. Iodine solution are discouraged for use in pediatrics. Okay, that's not, I think there are clarifications. Most of the people are thanking you for the presentations. Doctors, are there any more questions? I think there are no more questions. Thank you very much, Doctor, for the presentation. Let me take this opportunity to recognize the presence of senior dental surgeons, Dr. Isaac Okulo, Dr. Tom Mutiabule, Dr. James Magara, Dr. Kabenge, Dr. Aisha Batalingaya, Dr. Semakula Frederick, and others. Thank you very much for the attendance. Thank you, Dr. Samantha, for the presentation. It has been very wonderful and very informative.
Thank you for your time.
All right. If there's anything, any doctor have any communication, you can raise it. Or if there's nothing, have a good evening. Have a good evening.